Hello everyone, and welcome to the Murdoch Children's Research Institute Annual Showcase for 2021. My name is Professor Katherine North, and I am the Director of this wonderful institute. Our showcase today is being broadcast from the Murdoch Children's Research Institute in Parkville, located on the lands of the Wurundjeri people, and I wish to acknowledge them as our traditional owners. I'd also like to pay my respects to their elders past and present, and Aboriginal elders of other communities who may be watching us today. It now gives me great pleasure to introduce the Chair of our Board of Directors, Patrick Houlihan. In his spare time, Patrick is the CEO and Chair of the Dulux Group, and he brings to MCRI a wealth of experience in science, technology, industry and management. Over to you, Pat.
Well, thank you, Katherine, for the wonderful introduction. I would also like to add my own welcome on behalf of the Institute's board. Our annual showcase provides an opportunity, a moment in time, to pause, recognise and acknowledge the work of the Institute, our supporters and partners in giving all children the opportunity to live a healthy and fulfilled life. While we would obviously prefer to be with you in person, it is still wonderful to have the opportunity to engage with our passionate and enduring supporters and alumni, having met so many of you over recent years. It's also a chance to meet and connect with new audiences, and a special welcome to those watching an annual showcase for the first time. My own connection started in 2014 at a similar event, when Susan and I, as parents of 3 children, accepted an invitation by close friends to attend the Institute's Biennale. And soon after, I joined the board and recently was honoured to be asked to chair this great institute. In that context, I would like to acknowledge Susie Karp, who chaired the board for the last 6 years and has made a remarkable contribution over the last 20 years. This was deservedly recognised by her recent award as an Officer in the Order of Australia, and furthermore, a scholarship has been established in her name to support high potential early career researchers. My other personal connection to the Institute is anchored in my own science-based education as a chemistry graduate, my ongoing Dulux Group career, and my more recent involvement with the Industry, Innovation and Science Australia Board. Science enables so much of what we enjoy in society, and it is science that powers the amazing impact that MCRI has on transforming children's lives. Bringing this to life through the pioneering work of 1,600 brilliant scientists, with MCRI now global top 3 in children's health research. This year also marks the 35th anniversary since Dame Elizabeth Murdoch and Professor David Danks founded the Murdoch Children's Research Institute and created this amazing legacy that we, the current custodians, can build upon. In this context, it is timely to reflect on the founder's mentality, which is all about staying true to why we exist, which, at MCRI, is our enduring purpose of being for children and giving them every opportunity to live a healthy and fulfilled life. We do this by putting children at the heart of everything we do, with impact powered by research. I would like to end by acknowledging the many contributors who enable MCRI to deliver on this purpose. Firstly, thank you to Katherine North for her outstanding leadership of the Institute over many years and turning her inspiring vision into impact. In addition, thank you to our leadership team and all the brilliant scientists and staff who bring MCRI to life every single day. Also, to the MCRI Board of Directors, particularly noting Sarah Murdoch as co-chair. To our many board committees, including the development committees led by Sarah Murdoch and Mick Blythe, the Audit, Finance and Risk Committee led by Paul Rayner, the Investment Committee led by Simon Rothery, the Marketing Council led by Ian Rowden, and the Translation and Commercialisation Committee led by Geraldine Farrell. I'd also like to thank the VCGS Board, chaired by Brandon Karp, our campus partners, which comprises the Royal Children's Hospital, the Royal Children's Hospital Foundation and the University of Melbourne, our many other partners and collaborators around the world who work with us, and finally all of you, our passionate supporters. Thank you very much. I'll now leave you with this video which brings to life why MCRI exists, what we do and who we are here for. Enjoy the showcase.
Children are little miracles. They begin as just a hope and grow to a tiny movement, a heartbeat, a first breath.
And into the very first steps of life. While these little miracles continue to grow into even bigger miracles, many face adversity and some face serious challenges.
That's where the Murdoch Children's Research Institute and their amazing community of supporters come in. Murdoch Children's is passionate about giving all children the opportunity to live a healthy and fulfilled life. It's this drive that has led to the most incredible discoveries in child health, life-changing medical breakthroughs
That help our little miracles grow up to reach their full potential.
What a fantastic video, and such a wonderful tribute to the children, teens and families that are at the heart of everything we do at MCRI. The speakers that you're going to be hearing from today are truly driven by our goal to help every child reach their full potential. Thank you so much, Patrick, for that warm welcome to the showcase. It's been an absolute pleasure working with you during this challenging period. You bring such enthusiasm and experience to everything that you do. Now this year, Murdoch Children's Research Institute celebrates 35 years of helping children and families live happier and healthier lives. Back in 1986, two visionaries, Professor David Danks and Dame Elizabeth Murdoch, imagined a better future for children. They were driven by the recognition that 1 in 20 children is born with a rare genetic disease, which can cause very severe disease, birth defects, disability, and a high death rate. In fact, still around 1 in 4 children in the Royal Children's Hospital at any one time is there because they have a rare genetic disorder. The bold vision of David Danks and Dame Elizabeth was that genes may hold the answer to health and disease, and that genetics would one day become part of standard patient care. So in 1988, Professor Danks co-founded the Victorian Clinical Genetics Service, or VCGS, which is a pioneering not-for-profit subsidiary of MCRI, providing clinical care and diagnostic testing for thousands of children, adults and families who are at risk of or living with a genetic condition. So why did I say that David Danks and Dame Elizabeth were visionary? Let's go back to what things were like in 1986. 1986 was the year that the first human gene was cloned. 1986 was 4 years before the Human Genome Project began. This was a worldwide effort to sequence one single human genome, and it took 13 years and cost $3 billion to complete. Back in 1986, I was a young intern embarking on a career in child neurology. I became very interested in muscle diseases like spinal muscular atrophy, or SMA, which is a rare inherited form of severe motor neuron disease in kids. Children with the most severe form are never able to sit and usually die by 2 years of age from respiratory failure. These diseases were such a huge challenge and seemed at the time impossible to solve. But let's fast forward 35 years. Genomic medicine is an absolute game changer, allowing us to make rapid diagnosis, identify safer treatments, and change health outcomes for children with previously undiagnosable and untreatable diseases. For example, for our sickest children in intensive care, we can now provide a genomic diagnosis in under 3 days. Remember, that first genome took 13 years to complete. Over the last 35 years, our researchers have discovered over 100 new genes and contributed to the discovery of many more. And each of these discoveries impacts countless of lives of children and families here in Australia and around the world. From MCRI, we are leading a national program, Australian Genomics, a network of over 100 institutions around the country focusing on integrating genomic testing into clinical practice. As part of our research, we've demonstrated that introducing genomic testing early on in the diagnostic odyssey can increase the diagnostic rate from 10% to over 50%, and at a quarter of the cost of the usual diagnostic workup. By presenting this evidence to government and working with them, we've achieved in May of last year a Medicare item to provide genomic testing for all children in Australia who need it. That is a great achievement and something I'm sure that David Danks and Dame Elizabeth would be very proud of. And we're delivering genetically targeted therapies that can effectively cure these previously deadly rare diseases in children. The gene for spinal muscular atrophy was discovered in 1994, providing hope that one day we would understand why this disorder occurred and how we could treat it. And now, this year for the first time, gene therapy was delivered in the Royal Children's Hospital to kids with spinal muscular atrophy, giving them the promise of living relatively normal lives. Such a lot can happen in 35 years. MCRI has grown to over 2,000 employees, and while the Institute remains a centre of excellence for genomics, we've expanded our scope across many other scientific frontiers. And I'd like to acknowledge the great leadership of our other previous directors, Terry Dwyer and Bob Williamson. We've integrated genomics with stem cell medicine and clinical research. We are harnessing the power of big data and population-wide research. And we have a great footprint in global health to solve the biggest health issues affecting children and families today. One of our great strengths is our co-location and partnership with the Royal Children's Hospital and the University of Melbourne's Department of Paediatrics. But the Melbourne Children's Campus didn't happen by chance. It was pioneering people like Graham Barnes, Bob Williamson, Lindsay Cattermole, Laurie Cox and John DeCampo, who believed that a new approach to child health was needed, meaning that clinicians, researchers and academics had to build a village together. It was hugely bold at the time and quite unique internationally. At that stage, each department in the hospital worked separately and was separate from the community and public health groups. But the final objective to bring this all together was bang on. And while it took 10 years to become a reality, the initiative and the development of the Melbourne Children's Campus has proven its success. As you'll hear today, our clinicians and scientists work side by side to answer the big questions that arise daily in clinical practice across kidney and heart disease, youth mental health, head injuries, child stroke and more. We've developed national clinical guidelines, family-friendly digital tools, community and home-based care programs, and online educational resources in child and teen health, to name but a few examples. We think of research making a difference in 20 to 30 years' time. And going back to 1986, that was David Danks and Dame Elizabeth's thought. But increasingly, our research at MCRI is making a difference right now. Thanks to key philanthropic support from organisations like the Stafford Fox Medical Research Foundation, we've become a leader in stem cell medicine. Right here, we have the capability to recreate kidneys, cartilage, heart, blood cells and muscle in the laboratory from a child's own stem cells, paving the way for new approaches to diagnosis, treatments and prevention for many childhood illnesses, including kidney disease, heart disease and leukemia. We're also tackling the major health issues that are facing our society right now. The modern epidemics of allergy, obesity, diabetes, depression, anxiety, cardiovascular disease and cancer. All of these disorders have their origin in early life. For example, 1 in 10 kids have food allergies, and 1 in 3 of our children is overweight. Very worryingly, 1 in 5 kids growing up in disadvantaged environments are already intellectually impaired by the time they start school, perpetuating a vicious cycle of disadvantage. The dramatic rise in these chronic conditions globally has been described as an emergency in slow motion, and we have to address this challenge. Our researchers have been pioneers in establishing and running population-based cohorts and making huge strides in prevention and early intervention. Our goal is to change from a focus of waiting for a problem to happen and then trying to treat it, to really get on the front foot and prevent it from happening. Working at a never-before-imagined scale in Australia, we now host over 50 separate population-based life course studies involving over 50,000 families, millions of data points, and over 80,000 biospecimens. But this life course initiative is really just the beginning as we now start to launch large-scale community-based interventions. Generation Victoria, or Gen V, is the latest and greatest of our community cohort studies. After COVID interrupted the start of Gen V last year, since the beginning of October, we have scaled up so that we are now recruiting babies across Victoria in all 59 of the birthing hospitals. And it will be a complete overview of the entire population, encompassing people from all walks of life, from all ethnic backgrounds. Harnessing the power of artificial intelligence, bioinformatics, and health analytics at scale is the key to turning big data into personally relevant information, turning insights into solutions. And of course, we can't reflect on the last year without mentioning COVID, the world's most pressing health challenge of the last 100 years. The pandemic has amplified the importance and the benefits of health and medical research more than ever before. At the Institute, we've certainly played our part these past 18 months. Our COVID team of researchers has come together and made huge inroads into understanding what makes children's immune systems so good at dealing with COVID. Our stem cell researchers are modelling the disease in miniature organs and screening potential new treatments. And our vaccine uptake group has done a huge amount of work in convincing people to be vaccinated for their own health and for the health of their loved ones. In 2021, we again thank the state and federal governments for their ongoing support of the Institute's researchers, and we thank them too on behalf of the children and the families who ultimately benefit from this support. I'm sure that you'll agree that over the last 35 years, MCRI has grown the depth and breadth of the research that we do to become the #1 child health research institute in Australia, and we're now in the top 3 internationally. Over the next 35 years, we're focused on bringing the might of our expertise, our capability, our commitment and our enthusiasm to accelerate precision child health, to rapidly improve the prediction, prevention, diagnosis and treatment of rare diseases, of common conditions and complex diseases for children all over the world. And now let's move on to the main event of today, which is to showcase some of our fabulous researchers. It gives me great pleasure to introduce you to the first of these, Dr. Katherine Howell and Associate Professor Sebastian Lunke.
My name's Katherine Howell. I'm a neurologist at the Royal Children's Hospital and a Clinician-Scientist Fellow at the Murdoch Children's Research Institute. My area of expertise is epilepsy, and particularly severe infantile epilepsies. Now, these are really severe seizure disorders. Babies having many seizures every day, and they're often resistant to treatment. They're much more than just seizures though. 1 in 6 babies will die before their 2nd birthday. The majority of survivors will have significant developmental impairments. The longer that seizures are uncontrolled, the bigger the impacts on development. So stopping seizures promptly is of critical importance. But being able to stop seizures relies on understanding the causes of these conditions. Now, 35 years ago when MCRI started, we didn't know the causes of these conditions. We knew about the conditions, but not what caused them. It turns out there's a variety of genetic causes, but we didn't know that at the time. This is Levi. He started having seizures when he was just 1 day old. He had many seizures every day. He couldn't feed, and he needed help with his breathing. His EEG, his brainwave tracing, was markedly abnormal. 35 years ago, we wouldn't have been able to stop Levi's seizures, and he would have had really severe developmental impairments. Most children with his type of epilepsy would never sit or walk. I got into this field about 15 years ago because I was really frustrated by how little we could do for children like Levi. But between 35 years ago and when I started, there had actually already been some significant advances in our understanding of the reasons for these conditions through advances in genetic technologies. Now, standing next to me is Sebastian Lunke. Sebastian is an associate professor and he heads up the genomic division at the Victorian Clinical Genetics Service. Seb, you've been really heavily involved in this field for a number of years now. Can you walk us through what changed between 35 years ago and when you and I started in our fields?
Yes, Katherine. Let me start off by telling you a bit more about what I actually do. My lab is relying on a technology called DNA sequencing, which is essentially a very expensive way to look for typos in the blueprint that makes up the human body. Now, when MCRI and VCGS started out about 35 years ago, that technology was still very much in its infancy. Back then, scientists like myself had to manually and painstakingly separate individual bases of DNA on gels, take photos and count. Try that for all 3.2 billion bases in the human genome. It's really like trying to visit every country on Earth while riding a horse. Back then, we didn't even have a full human genome sequenced. It is only with the first revolution in DNA sequencing technology, a technology called Sanger sequencing, that we were able to start looking at conditions, genetic conditions that affect children. But we didn't even have a human genome sequence available 35 years ago. Only the emergence of Sanger technology allowed us to obtain that crucial piece of data that we now use to compare the DNA of healthy children to sick children like Levi. This equipment was standard in every genetics laboratory when I started out 15 years ago, and even today is still used as standard of care to look at small pieces of DNA and find things that make children sick. Would that have helped Levi?
Unfortunately, no, Sanger sequencing 15 years ago wouldn't have been enough. And the reason it wouldn't have been enough is that we actually only knew of a handful of genes for epilepsy at that point. And as you said, with Sanger sequencing, you needed to know exactly where to look. And at that point, we didn't know of any genes for the particular type of epilepsy that Levi has had. So sadly, if he were born 15 years ago, his treatment would have been the same as 35 years ago. But that's not the case today, and one of the big reasons for that is really the sort of massive revolution, I guess, in our knowledge that's come about over the last 15 years. And so compared with 15 years ago, we now know of about 400 genes for genetic epilepsies. And this has been a really big game changer because it means we can now give families answers about why their child has had the problems and symptoms that they have had. What would it have meant for Levi though? So if he were born 15 years ago, he probably would have been enrolled in research genetic testing. And as we found more and more causes, we would have eventually found his, and he might have been 8 or 10 years old. And by that stage, it would have been too late to help him. It's very different now to what it was 15 years ago. And that has all happened because of the second revolution, I guess, in genomic technologies.
Yes, see, the problem with Sanger sequencing, Katherine, is that it can only look at very small pieces of human DNA at any one time. So while it was indeed used to sequence the first complete human genome, that effort required hundreds of these machines, took 10 years to complete, and cost over $1 billion. It is really like having a car. You can visit every country in the world, but it's really not practical. To help children like Levi, we needed the second revolution in DNA sequencing technology, the emergence of so-called next-generation sequencers. These machines are now able to sequence dozens of human genomes in a matter of days for only a few $1,000s each. It's like traveling in a jumbo jet. But even that is not fast enough. Critically ill children like Levi need answers in days, not months. So what we really need is a fighter jet. And that is exactly what we built. Our acute care genomics project, which is co-led by Professor Sonitsa Stark and myself, is now delivering genomic test results for children all across the country in under 3 days. Levi was one of over 350 children that participated in the project. What did receiving his answer in under 3 days mean for him, Katherine?
It was a game changer, a massive game changer. Through the project, Levi was 2 weeks old when he got his diagnosis. And this meant that we could offer his parents, Kasha and Steve, a lot more than just an answer. We don't have a cure for his condition, but we could use the genetic diagnosis to guide our seizure treatment. We started a new medication and his seizures stopped. And instead of having hundreds more seizures, which is what we would have expected, he's had only 3. This is Levi on his first birthday. Through the Acute Care Genomics project, we've had 7 children diagnosed with exactly the same genetic condition as Levi. Every single one has had a treatment change, and they're all doing better than we expected. We've seen the benefits of rapid genomic testing across many childhood conditions, not just epilepsy, but we've still got quite a way to go to understand its full potential and to have it fully available to all children with suspected genetic conditions. Recently, we've teamed up with 3 other world-leading paediatric institutes, Boston Children's Hospital, Great Ormond Street in London, and the Hospital for Sick Kids in Toronto, to form the International Precision Child Health Partnership, or IPCHIP. IPCHIP's goal is to enable experts in child health and genomics to improve precision diagnosis, implement personalised treatment decisions, and develop novel treatments. And the partnership's first project is going to be one in infantile epilepsies. And we're really excited to have the collective might of these institutes to drive us all forwards. Seb, what do you see as the next revolution in genomic technologies?
What we have done over the last 35 years, I think, is incredibly exciting. Technology has progressed so much that we can now help many children with suspected genetic disorders, from neurological disorders like Levi's to metabolic disorders, heart conditions, and many others. But I think we've also seen that the faster we get an answer, the better the outcome for the child. So just imagine a future in 35 years where we can look at a child's DNA before they even get sick. I think 35 years from now, we will sequence every child's genome at birth, or even while they're still in the womb. That data will be used in their healthcare throughout their life. All of a sudden, we could have diagnosed Levi in a matter of hours, not days. In other cases, we may be able to predict conditions that affect individuals in the future when they are adults. We may even be able to predict conditions that affect their future children. The technology is here now. We just need the support to start using it. But not only will we be able to predict conditions, we will also be able to tailor treatments to the individuals and give them exactly what they need. That is one of your key areas of interest, Katherine, isn't it?
Yeah, absolutely, that's the goal. So we're very much in the infancy of the era of precision treatment, as we call them, personalised treatments, and certainly what we could offer to Levi was a personalised treatment, and we've seen the wonderful impacts of that. But to some degree, even that is just a band-aid, because really it's a treatment directed to the symptoms and not to the underlying cause. There's a lot of work going on around the world to develop treatments that are directed to the underlying cause and that hopefully will be able to cure these conditions. And I hope that in 35 years' time, we'll be able to offer all children with conditions like Levi's and many other genetic conditions a cure for their conditions. And hopefully rapid diagnosis will mean that we're in a position to implement them as early as possible when they'll have the most benefit. We'll go now to Kasha and Steve, who are going to tell us in their own words what a rapid genetic diagnosis meant for Levi and their family.
Hi, my name's Steve and this is my wife Karsha, and this is our 22-month-old son Levi. Levi was diagnosed with a rare genetic condition of epilepsy at the age of 3 weeks old called KCNQ2.
We just wanted to thank the Murdoch Children's Research Institute and Dr. Katherine Howell for the early intervention that they provided.
Without their support and guidance and all their research, it could have been months or years before Levi got his diagnosis. So to be able to get that in the first 3 weeks of his life and then prescribe the right medication to help with his seizures was a big relief to us, and we're really thankful and privileged to be able to be with Dr. Katherine Howell and all the Institute's support along the way. Without their support and guidance, we don't know where we would be today.
Thanks, Seb and Katherine, for that wonderful journey through clinical genomics and the terrific story of young Levi. I'm David Elliott, I head the Heart Disease Group here at Murdoch Children's Research Institute, and I'm joined by my friend and colleague, oncologist and clinician-scientist, Rachel Conyers, who's going to tell us a little bit about the history of cancer treatment. It's clear that clinical genomics has advanced a lot over the years, and one other area that's advanced a lot is oncology. So, Rachel, I'm wondering whether you could give us some sort of description of how oncology is advanced in the treatment of childhood cancers.
Yeah, sure, Dave. So one thing that people not realise is where the word oncology comes from. It comes from the Greek word meaning burden, which is a really apt description of what it means both physically and psychologically to have a diagnosis of cancer. We've certainly come a long way over the last 30 years. Back in the 50s, childhood cancer was incurable until Dr. Sidney Farber discovered the first chemotherapy agent that we now use today. And luckily today, 85% of children that are diagnosed with cancer will ultimately survive their disease.
So I think when we started working together, Rachel, one of the things that I was worried about, and I wonder whether other parents express this concern to you, is the side effects of these chemicals. They're quite toxic, so I'm wondering what sort of things you see in the clinic.
Yeah, so certainly the first question that parents ask us is this diagnosis curable? And the next question they always ask is about what side effects their child will have. And although the survival rates are excellent, you and I both know that 5% of childhood cancer survivors will have significant health effects as a result of having had that treatment.
This is an illustration of sort of the burden that you talk about that families face. And on the left here you have my son James, and on the right you have his friend Connor. And you can see they're both quite healthy. They're chewing down on what is not dog biscuits. They're actually gingerbread men baked by James's grandparents. But Connor had to have chemotherapy, so he's 15 times more likely to develop heart failure, 8 times more likely to have cardiovascular disease, and 9 times more likely to have a stroke. I think it's really important to note that heart failure, the only cure for heart failure is a heart transplant. And so this is something that families face and survivors of childhood cancer face. And you know, I think the major problem and the driving force behind our research is that we really want to tackle this problem of whether we can reduce this burden of cardiovascular disease in cancer survivors.
Yeah, I remember Dave 8 years ago scribbling on a whiteboard the beginnings of our research. And it's true that from little things, big things grow. We have a very large team, from scientists to medical students, PhD students, scientists, professors of oncology and cardiology. And now we have a national program across 13 institutes. And we're really looking to tackle cardiovascular disease at a big scale. This year we're opening 3 cardio-oncology clinics nationally. They're the first of their kind in Australia, and they will seek to understand the genetics predisposition to heart toxicity from chemotherapy. We're also looking to see with novel imaging techniques whether we can pick up heart failure earlier, and as Dave will go into in a bit more detail, looking to see if we can find drugs that protect the heart from these complications.
Yeah, so you know, the key driver for us is that we want to know which patients are going to be sensitive, and with that we use the sort of advanced genomics that you've heard described by Seb and Katherine. And the other driver is to whether we can come up with new medicines that protect the heart. And one of the strengths of MCRI is the stem cell medicine program, and we can take patient-specific cells and we can turn them into stem cells, and then we can turn them into these mini heart tissues that you can see here. So this mini heart tissue, this contractile is exactly the same as the child's heart, and it means that we can then look at see how they respond to drugs. So we have all sorts of genetic tricks we can do, and you can see, we can look right inside these cells and say, work out why they're sensitive, and then we can look for things that might protect them and protect them against heart damage from their chemotherapy. And so, again, as you mentioned, Rachel, from little things, big things grow, and this was an MCRI seed fund program where we used this pipeline to try and discover new drugs. So we started off with thousands of drugs and tested them against these stem cells in the dish, and then we looked to improve those, so that we're about to hundreds of drugs there, and we try and improve those. And then the next step is we take 20 or so into the mini hearts and really study them in detail. And now we're at the stage where we're looking at moving them into animal models as a precursor to moving them straight into the clinic and providing oncologists like yourself a treatment option to protect the patient's heart. So I guess I'm hoping that would help you down in the clinic, Rachel.
Yeah, so certainly 70% of the patients that I treat are exposed to cardiac toxic medications. So knowing who would be at risk of having cardiac complications would be really helpful, and also being able to give them drugs to protect the heart would be exceptional. I mean, ultimately our research, Dave, is to try and not have the cardiovascular complications of cancer therapy, to try and ultimately reduce the burden on cancer survivors so that there's really no cost of cure, but rather that there's just a cure of cancer.
And now we're going to hear from Tyler, who when he was 15 had heart failure and received a heart transplant.
When I was 15, I had a heart transplant. It wasn't known that I had cardiomyopathy until I got to the hospital, but I spent probably 6 months quite ill. And I also had lymphoma and had chemotherapy. Yeah, by the time I was diagnosed, it was almost too late. But I was fortunate enough to get a heart transplant, and that was 11 years ago now, and been doing pretty well. That's inspired me to be a nurse, lucky enough that I get to live a relatively normal life, and I'm looking forward to what technologies are going to come about in the future with disease modelling, with stem cells. Yeah, it's pretty exciting to see what's going to be coming in the next 10 years or so. And I want to thank the Murdoch Children's Research Institute for all the work they're doing, and one day we can get to the point where those who have heart failure can not worry as much and live their normal lives.
Thank you, Rachel and Dave. And what a remarkable young man Tyler is. Just an incredible story that shows the potential benefits of our heart research and of large clinical studies. In the 1990s, MCRI contributed to the setup of a Victoria-wide screening program to detect hearing loss in newborns. By 2005, we were identifying the genes responsible for deafness. And now we're going to hear from Valerie Sung about an innovative new screening test for newborns.
Hi, I'm Valerie Sung, Paediatrician and Clinician-Scientist Fellow at the Murdoch Children's Research Institute. My research interest is in childhood hearing loss. Let's wind back 35 years. This little girl is wearing hearing aids. Imagine what it was like for her back then. She would have been living in a world of silence until she was 2 to 3 years old, when her parents discovered she was mute and deaf. Now let's go forward a bit to 9 years ago, when my daughter Evelyn was born, and when hearing screening became universal in Victoria. Now, our campus staff deliver hearing screening to more than 99% of newborns in Victoria. That's around 80,000 babies a year. Of these, 160 have permanent hearing loss. In fact, hearing loss is the most common condition screened at birth. This is Kyle, 5 years ago, with his mum, Robin, who is my best friend from school. I still remember that day when Robin told me Kyle did not pass his hearing screen. She was devastated to find out he had profound hearing loss in both ears. But here he is now, all ready to go to school. Because he had early access to hearing aids, cochlear implants, and early intervention, he is doing so well.
Dear Mommy, happy birthday. I love you. Thank you for everything. Love, Kyle.
But not all children do as well as Kyle. In fact, many children with hearing loss still face a lot of challenges with their development and learning, and we still have a long way to go to understand why. This is me in clinic with Ned. As a paediatrician, I'm often frustrated I cannot answer some very simple and important questions that parents ask of me, like, why does my child have hearing loss? What will happen to my child? And how can we stop the hearing loss from progressing? One of the causes of progressive hearing loss is the virus CMV. It's the most common and potentially treatable cause of hearing loss and cerebral palsy. In 2019, we piloted a targeted screening program for CMV through 4 maternity hospitals in Victoria. We showed the program to be feasible and acceptable, with parents taking a very simple saliva swab from their newborns within 21 days of birth. We're now partnering with WEHI to turn the CMV screen into a rapid bedside test to make screening more efficient and affordable so that it can be rolled out across Australia. We're also partnering with GenV to work out how common CMV is in newborns in our community so that we can know whether universal CMV screening is needed. My research team has already made big impacts. In the next 35 years, I believe our work will address 3 main goals for families at the point of diagnosis of their child's hearing loss. That every child will access the appropriate services so that no child will fall through the cracks. That every family will have the opportunity to access funded genetic testing to find out why the child has hearing loss. And that every parent can be empowered with the correct information to know what to do and what to expect for their child's future. I leave you now here with Teddy, one of the babies who was discovered to have CMV and profound hearing loss through our screening program.
Hi, I'm Vicky and this is my son Teddy. Teddy was born with profound hearing loss through congenital CMV. Thanks to the work of the Murdoch Children's Research Institute, Dr. Valerie and all of the supporters, we've been able to make sure that Teddy has the best course of treatment to have a happy and healthy life. And we couldn't thank everyone enough.
Thank you, Valerie. And how energetic is little Teddy. What a gorgeous example of the impact research leading to clinical trials can have. It now gives me great pleasure to introduce the Institute's co-chair and our global ambassador, Sarah Murdoch. Sarah is such a passionate advocate for MCRI, promoting us as a global institute with our headquarters here in Melbourne. Thanks, Sarah.
Thank you so much, Katherine. And thank you for your whirlwind tour of MCRI's key milestones over the last 35 years. I mean, this institute never ceases to amaze me. To all of our dedicated researchers who we've heard from today, thank you. Your work and all the researchers and staff at the Institute have helped so many children and families, and your work will continue to do so in the future. And what you have achieved in yet another pandemic year is especially remarkable. I'd also like to thank the children and families of our speakers today for so generously sharing their time with us too. And of course, I thank you, Katherine. You have led this institute to greater and greater heights. We're now recognised as one of the top 3 child health medical research institutes in the world. But it is your humanity, your wisdom, your empathy, and the leadership you have given our entire team and your determination for medical research to make real change that has been so inspirational, particularly throughout this very difficult year. It's been over this past year that I've often thought how incredibly proud Dame Elizabeth would be if she could see the profound impact the Institute is having on children and families here in Australia and in countries right across the globe. I mean, it really is truly breathtaking to contemplate the breadth and depth of the work of the Institute and the potential that it has to change the lives of children for generations to come. So we stay determined and we will continue to find answers. Dame Elizabeth said she wanted to get to the root cause of what makes our children so sick, and that genetics might hold the key. Well, fast forward 35 years and it now seems entirely reasonable to believe that rapid genetic sequencing and diagnosis for the very sickest children will become routine care internationally, thanks to this institute, because Seb, Katherine and their teams are working in a supercharged global collaboration of the world's top 4 children's medical institutions to make this a reality for the 1 in 12 children affected by rare diseases. This will continue to lead to breakthrough treatments and ultimately, we hope, prevention. Like everyone who sees them, I'm so excited by David Elliott's ability to create miniature hearts in a dish. It's just incredible to see them beating away under the microscope, and it doesn't take much imagination to see how these tiny fluttering butterflies will one day lead to new heart disease treatments. And as we heard from Rachel, this work could also prevent the heartbreaking side effects caused by life-saving leukemia treatments. Thinking of our other stem cell work in genetic heart and kidney diseases, brain formation, neurodevelopmental disorders and stem cell gene editing, the next 35 years promises a revolution in the way that we think about treating previously incurable disease and disorders. When the Institute was first conceived, the focus was on rare genetic diseases. But the expansion into broader scientific areas to solve the many other health challenges that today's children face is really, truly exciting. Valerie's dream to introduce an innovative new platform to screen every newborn child for CMV using GenV as the test vehicle, we can one day hope to reduce the numbers of children around the world born with cerebral palsy and profound hearing loss. I still remember when my 3 children were born and had that standard hearing test. And I worried for them. It's nerve-wracking. But as new mums, we know having answers early is critical. So thank you, Valerie, for helping more families find life-changing answers sooner. The Institute's ambitious GenV program has already recruited 5,000 babies and their families. And I know our researchers would want me to especially thank these families. It's with your support and participation in a project like this that we can continue to make new discoveries and that will transform children's health. And internationally, our global health programs and partnerships in Africa, Southeast Asia and the Pacific are helping protect millions of children and young people from often fatal scabies, pneumonia and diarrheal disease. Of course, there's so much more that the Institute has achieved, not just in 2021, but over these past 35 years than what we've been able to hear about today. So I encourage you to head to the Institute website at mcri.edu.au, follow us on the social channels to find out more. But personally, I'd like to finish by thanking you, Patrick, for leading our board as we think about the promising years ahead, and my fellow board members for all the hard work you each commit individually in supporting the Institute. And thank you all for tuning in to watch this year's showcase. Please stay safe and well, and on behalf of all of us at the Murdoch Children's Research Institute, we hope you have a great end to the year and can enjoy this special time with friends, families and loved ones.